very good morning, everyone. Thank you for joining us for breakfast at UMHealth this morning. While Dr. Chow puts up her slides, I'll introduce this morning's first session. I'm Farah from the Department of Pediatrics, and I'm very happy to introduce our first speaker this morning, Dr. Chow Lai Yin, who joined the Department of Pediatrics at University Malaya in 2024. She has a strong interest in pediatric bioethics, and her CV boasts a lot of community work and work with marginalized children. And she's got special interest in community health as well. In 2023, she completed the certificate program in pediatric bioethics at the Children's Mercy Center for Bioethics in Kansas City. I hope you are as intrigued by the title of her talk as I am. So without further ado, over to you, Dr. Chow.
Thank you, Dr. Farah, for the kind introduction. Can everybody see my screen, Dr. Farah?
I think you're good. You're good.
Okay, good. So I'll get started. A very good morning to all my esteemed colleagues and a warm welcome. Today I'm going to make a sharing session about conversations, when things get difficult between the parents and also the doctors. And essentially, how are we going to navigate this? Essentially, that comes to the topic, fitting a square peg into a round hole. I've known nothing for disclosure. And here we are. It's not an uncommon scenario in clinical practice whereby the families or the parents or pediatrics point of view and the medical team disagree. Hence, we are technically speaking a different language. And how are we going to go about it in this situation? And what do we see here? Everyone has got two eyes, essentially, but no one has the same view, unfortunately. So what are we going to do about this? And this is a common clinical scenario we might see at work. For basis of content, I'm going to walk through. I have some story sharing, and later on, we're going to go on to some legal perspectives, all right, and some ethics principles, and essentially, how do we navigate this situation, how to fit the square peg into a round hole before we conclude the talk. The first story, we have got baby T.O.Z. He's a 1 year, 6 months old Burmese baby, and he has a background of tracheoesophageal fistula, who has undergone operative intervention twice due to recurrence, unfortunately. And with that, he had moderate tracheolaryngomalacia, complicated with a chronic suppurative lung disease, which required him to stay for a long, long time in one other medical institution. He came in very ill subsequently to our institution here. He was then stabilized and nutritional rehabilitation has to be done. So we diagnosed that unfortunately he had recurrent TOF for the second time, and again, surgery was done. Hence, this is the third round of surgery, and he has a prolonged PICU stay again. He was NIV dependent. It was challenging to feed. He was on TPN, and we were trying to escalate feeds. And ultimately, it was really difficult even to up-titrate the feeding. A little bit of the background family history. So over here, we have got a nuclear family whereby mother is the primary caretaker, whilst the father is really busy because he's the breadwinner. So most of the time, we actually essentially only meet mother in the hospital. There are 3 siblings. Mother actually just delivered another one. So there's a very young one in the family, plus an elder teenage sister. So it's really a challenging situation we can see here, whereby the youngest baby at home is predominantly taken care by the teenager sister, since the mother is now focusing more on sick middle child TOZ. As things get harder, the medical condition also gets more complex. So we now see that, while he's still staying in the hospital, his fistula recurred again, and now for the third time. The mother, being a very loving mother, as all mothers do, she requested that we go all out, in order to salvage the situation. And considering all this very complex medical condition and the family dynamics essentially looking all into consideration, our medical teams actually seeked out for hospital ethics consult and also initiated pediatrics palliative team referral. And at this time, mom was actually already raising her thoughts because she knows that we are deliberating on proceeding with the operation. She was already thinking of seeking opinion in other hospitals abroad if she's not given the chance to proceed with surgery for this particular child. So TOZ's general condition is really getting poorer. It's not helping the situation in terms of his lungs, which is one very very important determining factor in terms of his well-being here, and also his nutrition. So essentially, the ethics consult has proposed that we do not proceed with the surgery and instead, just focus on his conservative management. So this was then discussed with the mother again, and we actually suggested that we redirect focus to aim that the family concentrate on living well together, and to essentially live as a family unit, which they rarely get to do together. Most of the time was actually spent in the hospital. Mother finally agreed she could see that, this was probably a better option rather than pursuing this treacherous path of going through surgery again. So finally, that was the conclusion. And before the baby was discharged, mother finally got in some respite, whereby she had a sister who came over to help her out in taking care of this baby. And after discharge, this baby indeed managed to spend some quality times of several months at home rather than in a hospital. And finally, the baby succumbed. Mom did bring the baby in, when towards the final moments, and he succumbed at 22 months of age. Ultimately, mom accepted the death, and these were her words, when we met her after the death of the child. She said that he's not in pain anymore. He is now happier. And we can see that she could grieve and she could accept it, in an easier manner. So this is the first story which I would like to share. I've got another story of another child. And before that, we will have a little bit of a background discussion about the recurrent tracheoesophageal fistula. So this actually essentially happens in about 3 to 14% of children who has a background of, of esophageal atresia or tracheoesophageal fistula repairs. So whenever it recurs, it's really difficult to diagnose and treat. It's really complex, and it's usually associated with a very high rate of secondary recurrence again, morbidity and mortality. So we can see that, in our TOZ, he actually has got multiple recurrences, not just only once. And from literature, we could see that the mortality rates after, even after one time, it is actually 3%. All right, 9% of patients. This study has got about 31 patients in the study, and we have got 9 patients who actually had uneventful recovery, but also a big number actually we had lots of complications post-operatively, including anastomotic leakage, strictures, and again re-recurrence, which we can see in TOZ. So this is the next story which I would like to share, and this is a story of a very opposing family dynamics, which we would like to highlight here, which I would like to highlight here. This is baby R, who is a Malaysian here. He's born with Down syndrome with duodenal atresia, a very common association. He was discharged at day 2 of life from a district hospital after refusal of care. Unfortunately, on day 6, he came in with hypovolemic shock, with septicemic shock and pneumonia. He was then resuscitated and stabilized. Unfortunately, the parents again was not keen for treatment and requested for discharge against medical advice despite numerous and intensive counseling. So this is when the doctors had to proceed with child protection activation. And this is actually a very landmark case whereby the Child Act was actually tested in court with regards to such a situation. And in this, there was actually temporary custody granted by the magistrate to the child protector. So the child received state protection, right? And ultimately, it was a successful story. He was successfully operated and was also discharged back to parents under supervision by the welfare officer. Duodenal atresia is affecting about 5% of babies with Down syndrome. And we know that the standard surgical procedure is duodenostomy. There's actually quite low mortality rates, that's about 3% in recent years, mostly attributed not to this surgery directly, but to other associated anomalies. So that is actually a very excellent long-term survival number, more than 90% in literature. And diagnosis of Down syndrome do not significantly influence morbidity, and that is really important to note. So here I'm going to move on to a bit of discussions about how do we make decisions when there is conflict between the parents, the families, and the medical team. I'll share about some legal perspectives and also some ethical principles. So in terms of legal perspectives, commonly here we can actually utilize the Child Act. And in Article 22 and 24, it says that the medical officer has the authorization of hospitalization of any child who needs, who is in need of treatment or medical care. And also we are also needed, we are also authorized to exercise medical treatment if there is any need on such child. In terms of Article 27, this is when if we notice and we think or suspect that this child has been ill-treated, has been abused in any particular way in terms of physical abuse, sexually abuse, emotional abuse, or even neglect, it is compulsory and pivotal that the medical officer inform a child protector. And if there is failure of doing so, the medical officer can be convicted or liable to a fine or even imprisonment. This is about the Child Act. And next, I'm going to highlight about some ethical principles which we can actually utilize in order to look into our framework of managing and navigating this situation. We have the best interest standard, we have got the harm principle, and we have also got the zone of parental discretion. So a little bit more on the best interest standard. We always mention that we would like to act upon the best interest of the child, but what does this actually mean? So we have got John Lantos, a very prominent bioethicist who's also a pediatrician, who's mentioned the interest of children is actually neither very absolute, neither is it very clear. It's always very complex, intertwined with the interests of others, including their family members and including multiple other factors, and must be weighed against those interests. And we can then extend that it would include, all these other broader perspectives. Hence, we are going to balance between the benefits versus the burdens of treatment. And we have got another bioethicist, Koppelman. She has mentioned that it is not really exercising and promoting for what is ideal to a child, but essentially what is good enough in the eyes of reasonable people, whereby we ultimately want to maximize the child's overall well-being, the long-term benefits, and minimize harms and burdens. And this is the best interest standard. Now we'll move on a little bit more into the harm principle. We have Dikima, another bioethicist who has done a lot of work on the harm principle. He has mentioned that it is something beyond which parental decisions will not be tolerated, and that is when we can actually exercise state intervention to protect the child. And this intervention is only justified when parental decisions significantly increase the harms, the risk to a child compared to any other options we have. So essentially, state intervention is something which we will do as a final resort only when, this parental request actually cause substantial harm, sufferings, or even death. So this is something which Dikima has worked upon, a framework of questions in order to aid us to look into conditions which can justify state interference with parental decision-making. The next one is about zone of parental discretion. We have got some Australian colleagues, Gillum, who has came up with this concept. Essentially, we have times are really not, medicine is really not black or white. It could be very gray. So when we have got this situation here, we have got very clear, could be a situation where we have very clear indications that medical treatment is for the best interest of the child. But we also have got sometimes a very gray area whereby we are not too clear, whereby there could be possible benefits, there could be possible harms. And as a physician, we can sometimes accept parental decisions along this manner, but we would advocate for the child's and family's best interests. And if we move on further away, that is when we go on to the harm zone, right, whereby any decisions made in this zone is definitely of a threat, of risk, and of possibly risk of death to the child. And as physicians, we need to resist and override this decision-making by the parents. To make it simpler too, this is also a very useful model which we can utilize to look into the zone of parental discretion. And we have got the neonatal colleagues who have started to utilize this model much more initially, but we can actually extrapolate this to be utilized into the pediatrics population. So essentially, we have got we have got this line of prognostic uncertainty. So for example, whereby we have extremely very low birth weight babies, and as the prognostic uncertainty becomes more and more, as the baby becomes more and more premature, for example, that is when we have a bigger area for decisions for zone of parental discretion, because that's when we do not know the benefits, actually when it gets much not so clear, when the benefits of resuscitating are getting not as clear as the ones on towards the left, whereby the prognostic uncertainty is really very is definitely very clear that there is full decision making for resuscitation can be made here, and hence if any decisions is made otherwise, it's actually harmful to the child, and this would get lower and lower as the baby gets more and more premature. Hence, the zone of prognostic uncertainty gets bigger and bigger, and parents may have a bigger say here in terms of zone of parental discretion. And this can be extrapolated into any other pediatric situation whereby we see a similar zone of prognostic uncertainty as well. So hence, we will all go back to the question, which principle can we utilize, right? And there are lots of articles and journals who have mentioned about this. Now we go back to a little bit of a discussion of baby TOZ. We do see that he then presented with very poor medical conditions, whereby he has a poor lung condition, he has got poor nutrition. The ethics team has proposed for the fourth operation to not proceed, as it's highly likely that our baby will not make it out of surgery. So it's within the best interest of this child that further interventions are not done, and prognosis now is really guarded. So even if the parents, the mother, actually wanted to propose for, to proceed with surgery, it is actually a very narrow, very narrow window of zone of parental discretion to proceed with further operative intervention. And this is best interest to minimize further harm to the child, as we know that if you go on with operation, it might be very likely that he cannot make it out of surgery. In terms of baby R with duodenal atresia, it is actually the opposite situation, whereby parents do not want to proceed with surgery. And here it's really very clear that this baby with duodenal atresia would benefit tremendously from surgery. And it really crosses the harm principle limits if the parents disagree for the corrective surgery. The child has a very good chance of survival for this condition. As we look into literature, it's more than 90%, as I've shown just now, and we should not actually abide to the parental wishes, and state intervention must be sought in the situation, which we did, and the baby had the surgery successfully and he was well. So here we have a situation, a framework whereby when we have got conflicts, how are we going to move forward? I found this a pretty good model to showcase what we can best do. And certainly we would like to be in this particular quadrant of collaboration. And we want to have a win-win situation for the family, for the parents, for the baby, and also for the medical team. And hopefully we can actually have discussions to have some compromise within each and every party to have a collaborative win at the end of the day. At the end of the day, also, is all about maintaining relationship. We want to have trust, to maintain the trust between the parents, the family, and the doctors. And that is really, really important. So in conclusion, in order to fit the square peg, nothing beats the first, whereby it's about communication, and more communication, effective communication, which should be open, inclusive, transparent, and empathetic. And after that, we would like to probably relook and reframe the goals, and later on lead to collaboration and mediation in order to instill trust in the system between the patients, the family, and also the doctors. That's really so important. So ultimately, sometimes we may not sometimes be able to see eye to eye with our patients and our families and our children, but we can try to see heart to heart. With that, I thank you. That's the end of my presentation.
Thank you.
I'm open for questions.
Thank you, Dr. Chow. Those are very thought-provoking clinical cases that you've shared. And thank you for sharing the legal and ethical framework that we should think about in making decisions in the two situations that you've shared earlier. Any questions from the audience? Everybody's still digesting. These are not, I must say, they're not terribly uncommon, these cases. I mean, you do encounter them
Yeah,
rather
definitely.
frequently, isn't it? Um, if there are no questions, and perhaps if I may have one, I was just wondering, because
Sure,
we also,
Dr. Farah.
sorry?
Yeah, go on,
We
Dr.
also
Farah.
talked about, once these decisions are made by the ethical board or by the clinicians, and it's usually medically driven, and it should be. But so for the first case, how did we support mom when she in making her change her mind and accepting that decision to not proceed with any more interventions that will any more surgical interventions? What
Yeah.
support was available for mom, and how did she finally agree to that? Maybe that question first.
Yeah, we had lots of communications with her, and I think the teams noticed that, mom was really getting very tired. She has been going back and forth between different institutions, as it was the first institution, and then she came to ours. She was day in, day out, technically, with the baby, and the baby was very, very much attached to her. So it was as difficult as it was even to look into her own needs, in terms of toilet breaks, in terms of food, in terms of sleep. She could never move away from the child because the child constantly needed her attention. So we soon saw that there was a big need to assist her as well on top of the baby. So with that, we tried to explore what and how can we actually provide her respite in terms of some degree of respite, whether she can go back, have a bit of a rest, she can actually have a good sleep and she can attend to her own needs. So that was when she mentioned that she has a sister, all right, who also is a Burmese, and she was staying not far away from the hospital. So she could actually come over. Initially, she was very reluctant because she was really also similarly just as attached to her baby, which we can all understand, and she knew that the baby needed her too much. But after lots of talk, and we tried to be, empathetic and tell her that, you too also need the help and the support, because if you fall sick, nobody else can actually help you in the long term with this baby. And this baby needs lots of care and attention, regardless, of medical and surgical needs, also need lots of tender loving care, you know. So with that, she actually gave in and told that, yeah, maybe she can try speak to her sister, and that was when her sister came in on some days in the week, and also her daughter. She also roped in her daughter on some days. So on those days whereby her daughter came in, and that was when she went back and she took care of the other younger child instead, and she could also attend to, the other child's needs, because the child was also very, very young and also needed the attention of the mother. I think she was also very torn between how best can she juggle her responsibilities here, because she's got these three kids and one is really sick here, and she's trying her best, and we all know that.
Yeah. So maybe that little respite that she had, she was able to think things through a little bit more, perhaps. Do you think that was what
Yeah,
happened?
I think that probably made it clearer for her, because everything was there was just so much of information going in the hospital, and there was just so much of medical information, definitely, and then every day there are different teams coming in, and of course it's multidisciplinary, so right, so we've got the breast, we of course got the pit surgery, and we have got the we have got the initial teams for the pit surgery and the RESP and the general teams, and later on we roped in, of course, the PITS palliative care team as well. So there were lots of medical input coming in from different people. So definitely there would be some information overload there. And you definitely need to digest those information. Definitely, I would say I totally agree with you, Dr. Farah. Going back home then, whereby she had a better, clearer mind, she had a clearer perspective of what's going on. And it was actually aiding her in the decision making process, in the coming on board with us, essentially to look into, this child's gone through three operations already. We wouldn't want to go through another one whereby it's more perilous for him, since his condition is actually going down. really busy and he needs it in terms of financial support for the family. She probably also has done that with him, have a more collective decision and a clearer decision making for her in that sense.
Thank you.
Hello.
Thank you. I'm not sure if it's my connection or you're breaking
Yeah,
up a
sorry, I
little bit.
think it's a
Maybe
little
it's
bit
my
lagging
connection.
here.
Yeah. Do we have any more questions from the audience, perhaps? We have about 5 minutes more.
Right.
Maybe along the same line of thinking or same line of questions. What support was available for the second family? Must have been hard for them as well, not to see. I'm not. Wasn't quite clear what drove this decision of not wanting more surgery, but what support was available when the decision
Yeah.
was
So
not
for
in
this
line to
second
what they
family,
wanted?
yeah, thank you. So for the second family, this was actually was a landmark case of of our country, essentially, and this didn't happen in our place of work here. So essentially, what driven the decision making, I was speaking to the physicians who was in charge of this family. It seems to be more of there was some unshaken belief that this child doesn't need the surgery and they were worried about the risk of the surgery to the child rather than being 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 able to accept the fact that that the surgical risks are going to be really not that high, and the prospects of the child recovering is really really good. They were not really convinced and they were really worried. So with that, they had to actually step in with state intervention. But anyway, along the lines, the family was with the baby in the hospital. So this family was never really, the baby was never isolated from the family. So as long as this child is in the hospital, the parents and the family actually were with them, to what I understood from the physicians. Yeah, so it was never a thing whereby the child was taken over completely by the state, went on to a different
Right.
area, and the family was actually totally isolated. So in that sense, we really wanted to ensure that the baby gets the rightful care and support too, not just medically, but of course from their parents, because we know that the child needs the parents, and that can never be replaced by medical care and support. So in that sense, it looks like there was a balance. It's just that it's just more of overriding the family's decision to proceed with the surgery, but in terms of care and support and everything else, the family still managed to do that in the hospital settings.
Right. Thank you for that. We have about 2 minutes. If anybody has thought of something or has any more questions before we close this first session.
Right.
Oh, this looks all right. Okay. Thank you very much again, Dr. Chow. That was indeed a very good sharing session. And I will hand this over to Prof. Mohsin to introduce the next speaker. Thanks again,
Thank
Lai.
you.
Thank you, and thank you again.
Thank you all.